Sir, you can start.
Okay. Hello, good evening all. Myself, Dr. Datta Pawar. On behalf of Alkem, I welcome you all to this scientific session. Under our Women's Health Initiative, Break the Silence, we are delighted to bring the scientific session on ovarian cancer. And for this, we have Dr. Binu Walia with us as a speaker. She is a senior director, head of the Department of Medical Oncology, Clinical Cancer Care, Max Institute of Cancer Care, Max Healthcare Delhi. She is a renowned cancer specialist with more than 30 years of experience in treating cancer patients. And she is the first DNB medical oncologist of India. And she's one of the decorated oncologists in India, and she has been awarded various prestigious awards, to name few like Bharat Jyoti Award and Medical Excellence Awards by Indian Medical Association multiple times. She has also been awarded Inspiring Healthcare Leaders Dronacharya Award by Honorable Minister of State for Health and Family Welfare, Government of India, Sri Ashwini Kumar Chaubey. And she has been conferred this Certificate of Excellence at National Healthcare Conclave by former Union Minister, late Shri Anand Kumar. And she has been featured amongst 9 successful women by Outlook magazine in the edition of Stories of Women Remodeling the World's Landscape. And she has also featured in book titled Luminaries in Healthcare by India Today. And she is a keen cancer researcher and is principal investigator of various international clinical trials. And apart from that, she is author of a hugely popular book among cancer patients, that is Tips for Happiness in the Shadow of Cancer. And apart from that, she is also TEDx speaker. So I welcome ma'am, and we are very much delighted to have you as a astute clinician, then a keen researcher, a great orator, and as well as author. Thank you, ma'am, for joining us. Over to you.
Thank you, Dr. Pawar. Thank you for a very warm introduction. And I think before I begin, I must compliment the team for a very wonderful initiative, the Women Initiative, and very aptly named Break the Silence. Because women have always been the silent soldiers, the silent warriors among the family. And the disease which we are going to talk today is also known as the silent killer. Because ovarian cancer, we all know, is something, in spite of being so common, is generally missed in the initial stages and is generally picked up in advanced stages, because it being very silent in the initial stages. So I think, shall we start?
Yeah, ma'am, sure.
So let me share my screen first. Are the slides visible?
Yes, ma'am, they are visible.
Yeah.
So,
ma'am, just a second. Actually, I would like to make a request to all the gynecologists who have joined. Please share their comments and questions if they have in the chat box, so that we can take those explanation of answers from the Dr. Minu Walia at the end of this session. Thank you, ma'am. Over to you.
Without wasting much time, I'll start straight with the topic now. Break the silence, ovarian cancer. So ovarian cancer, I think, is something which is very close to every woman's heart. Every gynecologist, every practicing gynecologist must be really moved by this disease, and even we oncologists are, because it is one of a very common gynecological malignancy that we see in our practice. In the year 2020 only, there were more than 3 lakh cases worldwide, and in India, it is the second most common gynecological malignancy. In 2020, as per the records, more than 45,000 cases occur in our country only. And why it is so, why it is something which I said as a silent killer is that we all know as physicians, as gynecologists, as treating oncologists, that most of the patients invariably are diagnosed in when it is already advanced. So majority of our patients, they are diagnosed when it is already stage 3 or stage 4, because the symptoms of early ovarian cancer are generally so subtle and so vague that most of the times it is missed as acidity or some kind of bloating or gas. Many times patients are taking self medication only and they do not land up with the doctor. So while 75 majority of our patients will have an advanced ovarian cancer, but there is a silver lining to that, in the sense that ovarian cancer is a chemosensitive disease. So majority of these patients, once we give chemotherapy, they enter into remission also. And some of the unique features of ovarian cancer are that one is that more majority of the patients, in spite of some stage 4 in ovarian cancer, we will even when they are stage 4, we generally recommend surgery also. So majority of the patients will undergo abdominal surgery. Majority of these patients will undergo chemotherapy, and there is a lot more new things which have come up in the on the maintenance front also, because we know that there are many cases of ovarian cancer which recur also. So there are a lot of unique issues that ovarian cancer survivors face that also impact their quality of life. So just a short snaps at the diagnosis of ovarian cancer, the stage at which they are diagnosed and the 5-year survival. Needless to say, like any other cancer, the earlier the stage it is diagnosed, better will be the 5-year survival. In stage 1, where you have a 5-year survival to the tune of 85%, in stage 4, the same diminishes to just mere 12%. But look at the other figures. It is only 20% of the cases which will be diagnosed, or 20 to 25% of the cases of ovarian cancer which are diagnosed when it is a stage 1 or stage 2. That is limited to the ovaries or limited to the true pelvis only. Majority of the patients, 58 to 58% and 17%. So majority of the patients are diagnosed when it is already stage 3 and stage 4. And at that time, yes, the survival is already compromised. So a broad overlook, what is ovarian cancer? So this is a cross section of an ovary. We know that majority of the ovarian cancers, 95% of the ovarian cancers, they originate from the surface epithelium or the epithelial lining, and they generally have a serous. So those cancers which originate from the surface epithelium can be serous, endometrioid, mucinous, clear cell, or transitional. So 95% of the ovarian cancers will be of these type. The rest are 5% of the ovarian cancers can be either germ cell, the cancers which originate from the germ cells. So ovary, as it is composed of, apart from the epithelial lining, so there will be the sex cord stroma, the stromal cells and the germ cells. Tumors arising from the germ cells are also common, but in the younger age group. And then next comes the rarer tumors are your sex cord stromal tumors like granulosa cell tumor, thicomas, fibromas, etc. So when we talk of ovarian cancer, we are generally relating to the epithelial cancers of the epithelial origin, ovarian carcinomas that we are talking about. Coming to the risk factor of ovarian cancer, the most important risk factor is being woman. Yes, being woman, you have ovaries, and that is so. And as your age increases, the risk of ovarian cancer increases. As with many cancers, as the age increases, the risk of cancer increases. So, more than 50 years of age, the ladies will have an increased risk of ovarian cancer. Apart from that, this is one of those cancers where familial factors seems to be important. So if there is a family history of not only ovary, if there is a family history of breast cancer, family history of colon cancer, family history of endometrial cancer, even then the risk of ovarian cancer is higher. We know there are certain mutations like BRCA mutations which run in the family, which increases the risk of both breast and ovarian cancers and endometrial cancers, etc. And it is not only that the family history is important in the female members of the family. So even if the male members of the family have a history of breast cancer, they might be harbingers. These are the families where there may be history of BRCA mutation positive, or if there is a history of pancreatic cancers in the family, that also makes somebody vulnerable to ovarian cancer. So you have BRCA cancer syndromes, or you have even HNPCC, that is hereditary colon cancer, non-polyposis colon cancer, and risk of ovarian cancer may be higher in these familial syndromes. What are the other potential risk factors? The other potential risk factors is longer is your reproductive phase, so that the ovaries have to go through ovulation over and over again, and through all these multiple cycles of this degeneration and then regeneration, there is always a chances of some of these cells getting mutated and getting converted into carcinoma. So early menarche, the younger the girl starts having menarche, and late menopause. So early menarche and late menopause will make a lady more vulnerable, more at risk to have ovarian cancer. Similarly, hormonal replacement therapy may slightly increase the risk of ovarian cancer. Similarly, a first pregnancy older than 30 years, late first pregnancy may, and that is indirectly this only, that more ovulating cycles before somebody gets pregnant. Infertility, endometriosis, all have been found to be related to a slightly increased risk of ovarian cancer. So as we already discussed, the presentation of this cancer is something which is very, very vague, and that is why it is generally missed in the early stages. Most patients will only present with bloating or abdominal distension. So I think all of us will agree that majority of the patients that we see as ovarian cancer have been seeing somebody or the other for almost more than a year. So they have been going to either a physician or they are going to a gastroenterologist for the symptoms of acidity, heartburn, bloating, distension. And these are the vague symptoms that have been happening for quite some time before it actually comes to attention. So, and these symptoms, although they are vague, but they are persistent. So the clinical dogma always remains that for any symptom which is persisting beyond 21 days should be, even in spite of treatment for the same, should be taken much more seriously. So symptoms, they persist and increase over a period of time. And as already mentioned, majority of these women will present with advanced stage cancer and stage 3 and above, when cancer has already spread throughout the abdomen and possibly beyond. So, which I said that the presenting symptoms are quite common and are being overlooked, and it is very easy to be overlooked. For example, bloating is something that it is present in many cases, increased abdominal size, and even increased frequency of micturition. So these are the most frequent symptoms which are present. And invariably, if at all the patient is evaluated for these symptoms, you will see that they have come with an ultrasound of the abdomen, an ultrasound revealing a lesion, an adnexal lesion. So it is also very, very important for us to understand in whom to order an ultrasound and what type of ultrasound to be ordered, whether we should be asking only a TVS or we should be asking a whole abdominal ultrasound. So if there is a pelvic lesion, we want a better characterization of the pelvic lesion, then we generally ask for a transvaginal ultrasound only. If we combine it with an ultrasound abdomen, you will come to know not only about the pelvic lesion, you may have some other evidence of the disease. You might find some, apart from ascites, something if there is in the liver or something more than just a pelvic lesion only. A complex adnexal mass, any adnexal mass, depending on the age group, should be evaluated further. Characterization of adnexal masses are generally better delineated by a MRI of the pelvis. But if we want to do further staging workup, then CT scan is something that we do for the staging evaluation. PET CT in the basic diagnostic workup doesn't seem to hold ground. CT scan, a properly done CT scan is good enough for the staging workup. We may also have to resort to certain tumor markers. CA-125 invariably if is something that we very commonly do. Although we should always keep in mind that a raised CA-125 does not always mean CA ovary. For example, and also a normal CA-125 does not rule out carcinoma of the ovary. For example, in certain types of ovarian carcinoma, a mucinous type of ovarian cancer, if it is a stage 1 mucinous ovarian cancer, more than 50% of these ladies will have a normal CA-125. Apart from CA-125, HEE4 is also. So I'm talking about the tumor markers only for epithelial ovarian cancer. I'm not talking about the markers that we do for these stromal cancers or germ cell tumors. So epithelial ovarian cancer, CA-125 and HE4 are the ones which are very commonly done. And next comes the staging. And we all know the FIGO staging. Tumor limited only to the ovary, either one or both ovaries. Tumor beyond ovaries confined to the pelvis is stage 2, or both being called as early stage disease. Tumor beyond pelvis to the peritoneal cavity is stage 3, and beyond that is distant metastasis or stage 4. So what is important for us is, in present date, is screening and early detection of ovarian cancer. So what are the factors that may increase a woman's risk of developing ovarian cancer, which may reduce a woman's risk of developing ovarian cancer? So using birth control pills for more than 5 years, it has been found to be slightly protective in decreasing the risk of ovarian cancer. Breastfeeding has been found to be slightly protective. Pregnancy, again, possibly because there is no ovulation during those 9 months, is found to be slightly protective. For reasons unknown, tubal ligation and hysterectomy has also found to be protective for ovarian cancer. So if we know that certain families, they have these genetic syndromes, so there is a lifetime risk which is associated for ovarian cancer. For example, BRCA1 carriers. BRCA1 carriers have a risk of ovarian cancer to the tune of approximately 40%. BRCA2 will have slightly less, to the tune of 15 to 25%. Apart from, as I said, BRCA1 and BRCA2 are two of the more known genetic defects, genetic risk factors, but they are not the only genetic risk factors. We also know that if MMR, mismatch repair genes, if there is a defect in the MMR genes, then also there is an increased risk of ovarian cancer, ovarian as well as endometrial cancer. So going further, what are the red flags for cancer susceptibility? So it is very common that patients do not come with BRCA1 or BRCA2 report, but who land up with us is coming with a strong family history of cancer. So if there is a multiple family members who are having history of not only ovarian cancer, if there is a family history of breast cancer in the family, multiple members having breast or ovarian cancer, or if any family member have had cancer at a very young age, at less than 50 years of age, pre-menopausal, especially if we can extract history, if the lady has had triple negative breast cancer, that means which was hormone receptor negative and HER2 negative, history of triple negative breast cancer in the younger age group, 20% of these are known to be BRCA mutated. Any lady with a history of bilateral breast cancer, having cancer on both sides of the breast, either simultaneously or sequentially, had cancer on right side and then later had cancer on the left side. A patient who have had both cancers, same patient, or any family where there is a history of male breast cancer, male patient with a breast cancer are the ones where BRCA mutation testing should be done. And then Ashkenazi Jewish history and ancestry, so that they also have higher rate of BRCA mutation positivity. So these are all the factors we should where we should be asking for BRCA testing in our clinical practice. Coming to the natural history of ovarian cancer, the precise natural history of ovarian cancer is yet not really understood. I mean, unlike the cervical cancer, where we now understand the natural history, and that is why so many new things have developed to take control of cervical cancer. Ovarian cancer, we still do not know the precise natural history. There is no direct evidence for any pre-malignant lesion in ovarian cancer. And then the entire peritoneum is at risk because peritoneal carcinomatosis may develop even after an oophorectomy. So these are certain unique points that makes ovarian cancer so very much different than breast cancer. And in spite of knowing the high risk group, we really do not know how much difference we can make by being more aggressive. So many times, lot has been discussed about screening of ovarian cancer. And we know that whenever screening of ovarian cancer, whenever it has been tried in general population, the results have not been very encouraging. So in recent years, the focus has been on screening in the high risk group. So we have had various groups who have tried to do screening, UK-based studies who have done tried to do ovarian cancer screening in the high risk group. And how did they define the high risk group? Was basically the BRCA carriers or a strong family history of cancer. So these were those high risk groups, and where they tried to do screening of CA ovary with CA 125 and transvaginal ultrasound examination. And however, there was this UK phase 1 study and UK FOCCS phase 2 study, where apart from CA 125 and an annual transvaginal ultrasound, they also took into account the CA 125 value, the ROCA, the algorithmic scale of CA 125 value, to predict to pick up ovarian cancer early. And most of these studies, they showed that the positive predictive value was not very great in spite of the screen detected cancers which were picked up. For example, in the other study, there were only 12 cases of screen detected cancer, with although 42% of them were in stage 1 and stage 2. 11 out of these 12 cases, they underwent optimal cytodetection, but this cytodetection did not translate into cure. So, yes, high risk group, we do advocate that screening might help, but how much we are translating into cure is a big question. So major organizations all over the world do not recommend ovarian cancer screening. Definitely a no for a general population, because of the poor understanding of the natural history and poor performance of current testing in detecting early stage disease, and no survival benefit that has been found even in the high risk group. So no ovarian cancer screening for general population, but yes, some of the groups do talk about high risk group and screening in high risk group, and possibly that we can pick up the cancer in an early stage disease, although none of the studies have yet shown that there is a survival benefit. So in BRCA carriers, what we do for risk reduction of ovarian cancers? Risk reducing bilateral salpingo-oophorectomy. So risk reducing surgery where once the lady has completed her family. So if a patient who is a known BRCA mutant, BRCA1 or BRCA2 mutant, we generally encourage the lady to complete her family as early as possible by 35 years of age. And after that, we ask her to undergo a risk reducing bilateral salpingo-oophorectomy, which is known to reduce the risk of ovarian cancer by to the tune of 75 to 95%. So current estimated, do all these BRCA carriers they adopt this risk reducing surgeries or not. So yes, we know that some of the Western world also the adoption of these surgeries are to the tune of 40 to 50% only. So God forbid if somebody has ovarian cancer, just to give a overview of what management of ovarian cancer is all about. So once the patient present with symptoms suggestive of ovarian cancer, further evaluation is done, beginning with an ultrasound of the pelvis, and then yes, we have to go ahead and do a staging workup, a CT abdomen, and then depending on the stage, possibly a tissue diagnosis. If it is an early stage, stage 1 or stage 2 ovarian cancer limited only to the ovaries, then a tissue diagnosis is generally not warranted. We do not want to upstage the disease. However, if it is an advanced stage 3 disease or stage 4 disease, then definitely a tissue diagnosis is warranted. And all cases of ovarian cancer should be discussed in a multidisciplinary tumor board, where gynae oncology surgeon, a medical oncologist, a genetic counselor, a genetist, a molecular genetist, and all these should be part of that tumor board. Not all patients of carcinoma ovary will require surgery upfront. So this is something that is very, very important. There will be a subgroup of patient where we will be talking of giving chemotherapy upfront and doing cytoreduction later. And there will be a subgroup of patient which will be going for surgery upfront and chemotherapy later. But majority of these patients will require both surgery as well as chemotherapy. Patients can either go for a primary cytoreduction, that is primary surgery, followed by 6 cycles of chemotherapy, or we go for chemotherapy upfront, 3 cycles of chemotherapy, and then do interval cytoreduction, that is after 3 cycles of chemotherapy, and then complete the remaining chemotherapy after surgery. And then the patient is followed up. And we know that the general history of most of these patients is they may have a disease-free survival. Initial responses to chemotherapy are generally very great, but over a period of time, recurrences happen. Especially if it was stage 3 to begin with, recurrences are very common, and when you generally have recurrences, and many times even after recurrences, these remain chemosensitive, but recurrences are quite common, and with every subsequent recurrence, the disease-free interval seems to further shrink down. So ovarian cancer initial treatment evaluation by an oncologist, there are 2 major approaches. One is surgery followed by chemotherapy. That has been the traditional approach for patients who are surgical candidates and with resectable disease. The other approach is giving chemo upfront, then do surgery, and then complete the rest of the chemo. So for the patients who are not surgical candidates, who either have medical comorbidities or having too advanced a disease, having too much or gross ascites or too much of mental caking, in these patients, chemotherapy upfront is preferred. And also, if the disease is non-resectable, the disease being non-resectable, if there is evidence of disease at the splenic hilum, or evidence of disease at the root of the mesentery, or evidence of disease in the liver parenchyma, or there is a presence of pleural effusion, which is malignant pleural effusion. So these also make the disease unresectable, or probably at the initial evaluation, it seems like if the disease may be so much, there's so much that patient may end up going for a very extensive surgery requiring colostomy and all these, then these are the patients which are better to be given chemotherapy upfront. Even ladies with gross ascites, there may be one thought which may talk about neoadjuvant chemotherapy, that is first chemotherapy and then surgery. So several large randomized trials have been done so far, which have compared these approaches and at least demonstrated that if it not better, but definitely chemotherapy upfront is not worse, is not inferior than doing surgery first. The chemotherapy, normally there are 2 agents that we use, paclitaxel and carboplatin, and most patients will require 6 cycles of chemotherapy, which will be given every 21 days. And following aggressive surgery and chemotherapy, majority of the patients will have a good response, will enter into remission. However, but that is not the end of the game. So even if a lady has entered into remission, has been cured of, say, ovary, it is always recommended that they should have a close follow-up. So follow-up is always advised. So patients may go back to their local physicians, can go back to their gynecologist for follow-up. So what is important is that the initial frequency of follow-up. So initial 2 years, it should be done at least every 3 months. And after that, for next 5 years, at least every 6 months. And beyond 5 years, also the follow-ups do not end, and it is recommended an annual follow-up. And every follow-up visit to the clinic, what needs to be evaluated is a symptom evaluation. Any new symptom which is developing, history taking is very important, and a pelvic examination, which is an important part of the follow-up. Do we do PAPs? No, PAPs are not recommended for ovarian cancer follow-up. And what about CA-125? Do we do a CA-125 at each follow-up? So if the initial CA-125 was raised, then yes, CA-125 will have a value in follow-up. However, if the initial CA-125 was never raised, for example, in mucinous carcinoma, then there is no value of doing a repeat CA-125 during follow-ups. What about radiographic imaging? So do we do X-ray and ultrasound? At present, there is insufficient data to support that they are mandatory. But yes, in most of our clinical practice, we also do an X-ray and ultrasound in follow-ups of these patients. So when should we do a CT or a PET-CT scan? So what I will say is a PET-CT scan has got much more value during follow-up than in the initial diagnosis of these patients. If a patient is symptomatic or the CA-125 is rising, so that is the time that when a PET-CT can be done or PET-CT should be done to pick up the recurrences. So surveillance and monitoring, I already talked about. One is CA-125, which is the most commonly followed tumor marker. But one should know that even case of CA ovary can have a normal CA-125, and it is not only CA ovary that in cases where CA-125 is raised, there are many other benign conditions also where CA-125 may be raised. For example, if there is tuberculosis of the abdomen, we frequently see CA-125 raised. In endometriosis, CA-125 can be used. In many benign conditions also CA-125. Cirrhosis of liver, CA-125 can be raised. So many benign conditions also CA-125 can be raised, and it is also not the level. For example, I have in my own clinical practice, I have seen CA-125 to the tune of 3,000, 4,000 also, and later the lady turned out to be tuberculosis of the abdomen. So CA-125 raised is not diagnostic. However, it helps in case where there is a tissue diagnosis of malignancy. It will definitely help in monitoring these cases. So it is a corroborative. Then another marker that we use is HE4, which may be elevated in patients who may have a normal CA-125. So for certain histopathologies, for example, endometrioid subtype, HE4 may be of more value compared to CA-125. So do we have to follow CA-125? If the initial CA-125 was raised, then definitely all oncologists, we always follow CA-125 during their follow-up visits. But what we need to know is very frequently that during follow-up, we find that after a while, the CA-125 starts rising again. However, if we get a PET scan, as is recommended, if your CA-125 is rising, you should get a PET scan done. If we get a PET scan, there are chances that the PET scan is absolutely normal, but the CA-125 is rising, and this is what is known as the serological relapse. So serological relapse, when only the CA-125 is rising and there is no radiological relapse, there is no evidence of cancer in the radiology. That is also quite common. So the next big question is, how do we address this? How do we deal with these patients? So serological relapse invariably after a gap of 3 months, 4 months, 5 months will be followed by radiological relapse also. But there are studies that if we act early, if we start giving chemotherapy while the patient have had serological relapse, there is no difference in overall survival. Whether you act early, whether you give chemotherapy at the time of serological relapse, or you wait till radiological relapse, the overall survival remains the same. So whether to treat or not to treat at this point of time is generally an individual decision that one needs to take depending on how symptomatic the patient is and discussing everything with the patient. So again, the next big question is, do we do a CT scan on a regular basis? There is no role of routine imaging in a cancer, in a ovarian cancer follow-up. And these CT scans generally are not recommended. The only place where we do recommend CT or PET scan is if the patient is symptomatic. If there is a new onset of symptom or the tumor markers are rising, then yes, on follow-up, a CT or PET scan is recommended. PET definitely in this setting is far superior than CT scan alone, because it may pick up disease which a CT may miss. Then genetic testing. So how frequently and which are the ovarian cancer patients for which genetic testing should be done? Ideally speaking, all patients diagnosed with ovarian cancer should undergo genetic testing for hereditary breast and ovarian cancer genes. So yes, that is it. The recent guidelines, the latest guidelines, NCCN guidelines, all major guidelines, they recommend all ovarian cancer patients, especially all high-grade ovarian cancer patient, every patient, irrespective of the age at which it is diagnosed to have ovarian cancer, should undergo genomic studies. Now, the next big question is, shall we be testing only for BRCA mutation, which are more commonly known, or we should be testing for a complete hereditary panel? So in an ideal setting, we should be testing for a complete hereditary panel where you will be testing not only for BRCA genes, but you may also be testing for homologous recombinant HRR genes and various other genes also, which may have some implication. However, if a lady cannot afford a complete genomic panel, then minimum BRCA1 and BRCA2 should be tested. 15 to 20% of the ladies with high-grade ovarian cancer, especially high-grade serous ovarian cancer, are known to be carriers of BRCA mutation. So BRCA mutation testing, if we have to do, then what is the ideal tissue? What it should be tested on? Shall it be tested on the tumor tissue, or shall it be tested on the blood, that is the germline mutation? Ideally speaking, both should be done. We should test it on the tumor, that is the somatic testing should be done, and we should also test the blood or the saliva for germline mutation testing, because both have its own implications. So why it is important to undergo testing? Why? Because there is an implication not only for the patient but also for the family members. You may need to do certain counseling, you may need to do genetic testing of other family members, you may be able to pick up high risk cases, and you may have to advise them regarding certain risk reduction surgeries, or probably lifestyle management, or probably just being more vigilant. And and even for the patient, if a patient is found to be BRCA mutation positive, if a lady is found to be BRCA mutation positive, the implications for the treatment. In today's date, we know that there are certain targeted medicines. There are certain targeted medicines which act very well in this BRCA mutant carriers, PARP inhibitors, and which improve survival of these ovarian cancer patients significantly. So there are implications, therapeutic implications, treatment implications, and further treatment options needs to be discussed. So needless to say that since This is a long treatment and there are multiple recurrences. So it is very important that quality of life issues are taken into consideration. Patients not only physical well-being but emotional and social well-being also needs to be taken into consideration. And for all of us, it becomes important that we address these other issues, the psychiatric issues, the psychosocial issues, and how she can maintain a healthy lifestyle. Coming to almost the last part, what is new in ovarian cancer therapy? So a lot is happening in ovarian cancer therapy. Fortunately, in women cancers, there seems to be so many different things that seems to be happening in ovarian cancer also. There are new cell targets. The whole concept of oncology is now shifting from broad principles to targeted therapy. So new targets are being identified. For example, BRCA mutant, if we can identify certain subgroup of, and it may not be only BRCA mutation, if they are HRR homologous recombinant repair mechanism deficient families, if they are recognized, then you can have directed therapies. There is some role of immunotherapies, so there are being efforts to understand which are the ones where there may be some role of immunotherapy, or there may be role of targeted therapies like anti-angiogenesis therapy. So there are, we know that any cancer, for it to survive beyond 1 centimeter in size, for it to spread in the body, it requires blood vessels. So anti-angiogenesis therapy, which cuts down the blood supply of the tumor, also helps in management of these cancers, and now have found a role in management of these therapies. So many different agents are available, targeted therapies are available, immunotherapies are available, and even your PARP inhibitors for BRCA mutant cancers are available, which decrease the chances of recurrence. So where are we in cancer therapy in present today date, in today's date? So there was a time where it was uh, empirically determined therapy for all cancer patients. So what used to happen is all ovarian cancer patient will be dumped as one, all breast cancer patient will be dumped as one, and they will just have the same routine empirically determined therapy. But in today's state, what we seem to be moving towards is molecular based therapy. That is why the essence of doing more and more genetic testing, genomic testing, and identifying the unique molecular signature of these cancers so that we can give directed therapies for it. And this is always my favorite slide. And one day probably I wish cancer would only, when we talk of cancer, people only think of that zodiac sign. And we are probably able to spread so much of awareness that most of these cancers, or probably the diagnostic abilities become so good that we pick up these cancers early, and cancer will only mean a zodiac sign one day. And with that, I say thank you, and thank you all for a very patient listening.
Thank you, ma'am. Thank you very much for this wonderful talk. So, ma'am, I have a couple of questions with me. As you said that symptoms are very vague and many are missed at early stages. So, ma'am, what can be done to increase the early detection rate? Are there any red flag signs which you mentioned? Obviously, the patient family history and the mutations. But apart from that, is there anything which can be done? Especially because many such patients uh, go to the gynecologist or primary their family physician. What are those symptoms, red flags, anything uh, through which the early detection can be increased?
Sorry, can you come again?
Ma'am, as you mentioned that these symptoms of this disease, ovarian cancers, are very vague, and many are missed at early stages. And so, what can be done to improve the early detection of these cancers? Are there any red flag signs or red flags apart from the family history or mutations? Is there anything which can be done to improve the early detection, especially at the gynecologist level or family physicians level who are listening to this talk?
So the most important thing is family history. And if a patient is a known BRCA mutation or any genetic mutation carrier, so these are the most important things. Apart from that, the red flags also includes even ladies who are presenting with vague symptoms and the symptoms not resolving beyond specific therapy beyond 3 weeks. So any symptom that persists beyond 3 weeks should be taken seriously, and we should at least be asking for an ultrasound. And then, yes, the whole story starts. If the ultrasound picks up a cystic lesion in the ovary, then it is a complex cyst or it's a simple cyst, whether it is disappearing or it is increasing over a period of time. So these are all where we should make us alert towards the possibility of any abnormality or any cancer.
Okay, thank you. So, ma'am, there is another situation wherein many times gynecologists suggest advice of ultrasound scan, and some cyst actually appears incidentally or because of some symptoms, abdominal symptoms. When gynecologist treating physician should be suspicious of malignancy when she or he sees that cystic lesion. Or
So,
yeah.
an approach to an adnexal cyst or ovarian cyst is a very, very complicated thing. And this is something which is of prime importance in clinical practice. First and foremost, what is important is the age of the patient. So if whether the lady is postmenopausal or the lady is premenopausal, or that is very important. Then the other thing that needs to be looked at is the size of the cyst. And the most important thing is whether it is a simple cyst or it is a complicated or it's a complex cyst. So we know that what malignant lesions will look like. A malignant cystic lesion of the ovary is more likely to be a complex cyst. It may have nodularity, it may have cystic and solid components both, and it may have multiple septations. Then a size is also a very important parameter. Although from textbooks to textbooks and authors to author, the cutoff size has varied, but for most people, the most guidelines will take 7 to 10 as an average. Any cyst which is more than 10 centimeter in size should be taken with an index of suspicion. So, and the index of suspicion has to be higher in a postmenopausal group. For example, in a postmenopausal lady, if a cyst is more than 5 centimeter in size, that should be taken with a pinch of salt. And however, in the reproductive age group, we know that these cysts may be just because of your ovulation or hormonal changes. So if there are simple cysts occurring during different phases of the cycle, that can still be ignored. Similarly, in a premenarche, if a girl is presented with a cystic lesion, to extremes premenarche or postmenopausal, the cystic lesions have to be taken more seriously. In the reproductive age group, also we have to be alert, but we will then be looking out whether it is a complex cyst, if it has a solid cystic pattern, how much is the blood flow, and all these parameters need to be taken into consideration.
Okay. Thank you, ma'am. So, in this situation, if there is a suspicion of having a malignancy, what other tests are recommended, means should be advised by the gynecologist, or when should that patient be referred to oncologist for the management?
So if there is a cystic lesion in the ovary, the next thing what we say is, for better delineation of the cyst, we should ask for a transvaginal ultrasound. If our transvaginal ultrasound says there is a possibility of a malignant cyst, or if the transvaginal ultrasound also doesn't give us a clear-cut answer, then a contrast enhanced MRI of the pelvis generally helps us to delineate that lesion further. So if it is a complex cyst or a solid cystic mass suspicious of malignancy, then we need to evaluate further. What we need to do is, at that point we generally ask for the tumor markers. So depending on the age group, we ask for the tumor markers. CA125 and HE4 are two tests which we very commonly do. If it is a younger age group, if a young lady, then you go for your germ cell markers like beta STG, LDH, alpha fetoprotein. So these are the markers which we very commonly do. You ask for the tumor markers, and then a correlation needs to be done, looking at the tumor markers, looking at the radiological picture, what is the probability of it being malignant, and then depending on the stage. So you do a staging workup. If it is an early stage disease, then you proceed further with possibly surgery alone. If it is an advanced stage disease, then the discussion comes to whether you have to give chemo upfront and then surgery and all these things.
Okay. Thank you for that. So in this situation, the tests which are advised, fine, ma'am. But suppose a patient with just vague symptoms and comes, and when should the test should be advised? And you mentioned that the CA-125 and other tests, their prognosis, their value as a screening parameter is very low. So is there any battery of tests which can be used routinely for such screening for such patients?
So, as such, I said the routine screening for CA ovary is not recommended in normal risk population. If a lady is presented with vague symptoms, then you generally try to treat those vague symptoms also. So, if the symptoms look like acidity, if the symptoms look like retrosternal burning, you generally go for that treatment also. But any symptom, again I come back to, any symptom persisting for more than 3 weeks in spite of treatment should be taken with a pinch of salt and evaluated further.
And ma'am, apart from this, so this was regarding the oral testing and screening. But when you come to the treatment, any advantages, like in terms of, you mentioned about there is targeted therapies like immunotherapies or PARP inhibitors. Are do they hold any promise in complete cure or cure treatment of this such patient? How they are promising, how much they are promising?
So definitely the newer treatments hold a lot of promise. For example, we have data from our all these studies that PARP inhibitors, for example, it is found effective not only in BRCA mutation carrier, but non-BRCA mutation carrier also in increasing the relapse-free survival or disease-free survival. So especially if it is a patient is a BRCA mutant, then we are giving PARP inhibitors in maintenance also. So after completing chemotherapy, you start these patients on oral tablets, you give PARP inhibitors and increase their survival. The same goes for your bevacizumab and other anti-angiogenesis agents also. Unfortunately, immunotherapy so far has not found ground in ovarian cancer, but probably we have not yet found or identified that subgroup of ovarian cancer where immunotherapy may be acting. Maybe in near future, we will identify those subgroups also.
Okay. And regarding this young patients, though they are less common having ovarian cancer, how to preserve fertility in such patient, ma'am? Is there any impact of chemo on fertility, and how that can be prevented or preserved?
So yes, chemo definitely has an impact on fertility, but what is important is that it is the survival comes first, the patient comes first. Then, however, if it is a tumor with a something like borderline ovarian tumors, then we can go for fertility sparing surgery. You can just remove single ovary and single tube and leave the uterus and the other ovary behind. Or if it is a germ cell tumors, where the patient have wonderful survivors and you have long-term survivors and beautiful responses to chemotherapy. So fertility sparing surgeries are being talked about. But in cases, if it is a high-grade serous carcinoma stage 3 disease, where there is no role of any fertility sparing surgery, where you will ultimately have to remove uterus and both the ovaries. So fertility sparing surgeries, fertility issues are definitely a concern, but fertility sparing surgeries are being talked about in tumors with limited stage disease, or in borderline ovarian tumors, or in germ cell tumors.
Thank you, ma'am. Thank you for this wonderful explanation. Vishaka, are there any questions from participants?
Yeah, there are two questions which I have just pasted in the chat box.
Okay, the importance of HE4 in diagnosis of ovarian cancer, ma'am. Would you like to take this?
So HE4 is found to be slightly more specific as compared to CA-125. However, the problem in our country is there are not many labs which are doing HE4. The turnaround time is almost 4 days. The availability of HE4 is more limited. But yes, if it can be done, it also improves our pickup rate of ovarian cancer. And especially, I said endometrioid histopathology. In CA ovary, which are endometrioid histopathology, CA 125 can be normal and HE4 may be raised.
And there is another question regarding CA125. How much is the importance of CA125 marker useful in detecting ovarian cancer?
So as I mentioned, CA125 is something which is raised in lot many. It is not raised only in ovarian cancer. It may be raised in lot many other conditions also, and even lot of many benign conditions also. So just a raise CA125 cannot be taken as diagnostic of ovarian cancer. But if CA125 is raised and along with other radiological features, then it can act as a corroborative factor. So what the value of CA125 is more in following up for recurrences. So a lady who had a high CA125 during follow-up if you see a rising CA125 level, to pick up recurrences earlier CA125 has got much more value. In the initial phases, it is more of a corroborative factor rather than diagnostic factor.
So there are no questions, I think. So yes, thank you very much, ma'am, for this wonderful presentation, and you explained beautifully all these important aspects about management, detection, and all the aspects about the ovarian cancer. So on the behalf of Alkem, I would like to thank you for taking time from your busy schedule and explaining on this topic. And I would like to also thank all the participants, gynecologists who have joined this session, from taking time from their busy schedule and making this event successful. Thank you once again. Bye, ma'am.
Thank you.
Thank you, ma'am. Thank you so much.
Thank you.